we move on to the clinical part, which is essentially what we are serving. And we are very lucky to have. Thank you very much, Dr. Varsha.
Thank
It's
you, sir.
it's
Thank
a
you, sir.
pleasure talking to you.
Thank
And now we have Dr. GC Khilnani, who was professor and head of pulmonary medicine in All India Institute of Medical Sciences, and he's now the chairperson in PSRI Institute of Pulmonary Critical Care and Sleep Medicine. He is a world-renowned physician, and he would tell us about the clinical part, which is why the lab exists to help them, and we need to listen to them carefully about their needs, what where we can help, and what he feels is this new outbreak that has occurred. Should we be concerned, or there are things to watch out for? Dr. Khilnani, please.
Thank you very much, sir, for your kind words. It's a privilege to be amongst the top virologists of this country and the world, and for which I thank Dr. Ekta and Kaho and also Indian Society of Virology. I'll share my slides. So, good evening, everybody. So, you will have to get into a different mode to be with me in this 15 minutes presentation, because I am going to talk about clinical pictures of whatever you information you give us, the virologist and the microbiologist. We thrive on that and act in a way according to your directions. So nobody can forget the tsunami of COVID pandemic, where 7 million deaths were there, and as many as 3 crore 83 lakh people require ICU care, with half of them requiring mechanical ventilation. And there's nobody who hasn't lost a near or dear or a relative or close relative. It was a And then the COVID warriors, which had higher mortality, especially before the vaccination came in. They actually, and we saw very peculiar things in this world, with two people on one bed, oxygen shortage, and the railway trains being used for isolation, and 5,000 bed created in a pandal kind of a thing. And sometime in the Italy, one ventilator was used to uh, ventilate two patients. And of course, we all were going on television creating public awareness. And I got into the habit of writing as the literature was coming, and I used to write blog on IgG antibodies, and I used to write my opinion for my fellow practitioners and specialists, whether it was steroids or whether it was use of remdesivir. Every day there was information pouring and talking about immunity. I used to write my take on the subject and give my thinking on that. And information was pouring. So when I got this chance to address virologists, I didn't know how to handle it. So I thought how to make it clinical and how to prove upon my point. So I brought about a case which I saw initially when the pandemic came. The testing was limited. This was a 58 years old male who is a radiologist in our hospital, who presented with high grade fever, sore throat, headache, and breathlessness. He had fever when he came, and his ABG showed he had hypoxemia. Since he was a radiologist, even before coming to us, he got a CT scan done. If this was in the middle of the pandemic, looking at the CT, we would have said that, okay, this is classical COVID, but we didn't know that actually at that time. So he was started on IV antibiotics, steroids, since there was hypoxemia, anticoagulants, but RT-PCR was negative. There was lymphopenia, the D dimer was normal. It showed TLC was little low, ferritin was high, CRP was normal, and procalcitonin was also normal. So on the day of admission, which was almost seventh day of his illness, he again did the CT, and the shadow, the consolidation or the alveolar shadow increased. So RT-PCR were again negative when we tested. And the ninth day, the second PCR was again negative. So we were perplexed how to handle. We presumed that it was, and third COVID RT-PCR was sent, which came out to be positive. This was almost 10th day of his illness. So this is showing you the clinician's dilemma in the beginning of it. The ferritin was continues to be high. And the day 4 of admission, that is almost 10th day of illness, he had bradycardia. The heart rate was dipping. He was 58, no history of CAD, no comorbidities. His trop T and 2D echo was normal. You see, his heart rate was dipping like this, and we were so worried. So he was monitored, and liver functions were also deranged. And repeat CBC was done. The TLC was still low. Ferritin came down, and he was discharged. And on the eighth day of discharge, he continued to have fever, and he lost around 8 kilos of weight. He again was admitted, was given antibiotics. Just cutting it short, this was his CT scan subsequently, but later on everything resolved and he became normal. So when he was discharged, he had O2 support with 94. So this during the pandemic, the most common symptoms were fever, dry cough, tiredness, difficulty in breathing, chest pain. The less common symptoms were aches and pain, sore throat, diarrhea, conjunctivitis, headache, loss of taste, a smell, a rash, or a skin. We saw things which we did not see so often. This was a 35 years old, obese female, no comorbidities. All the Their score was 25 by 25. The whole lung was affected. She had pneumomediastinum also. We saw a whole lot of pneumothoraces. And we saw the lungs being totally studded with consolidation. And we also saw the post-COVID pulmonary fibrosis. You can see here bronchiectasis, dilated bronchi. This patient is still following me up. He has a bit of breathlessness, but leading a reasonably normal life. But majority of time, these shadows disappeared, and over a period of months or a year, the CT became close to normal. Now, coming to the resurgence of COVID, what has happened this time? So, Ministry of Health have this is yesterday's data. There are active cases of about 5,000, but I believe there are several folds more cases. When we test it, we are finding it positive, and Kerala and Maharashtra have the highest number of cases, and also Tamil Nadu. And this is a dashboard of WHO. This is the pandemic time. The COVID has been endemic. If you can see the number of tested SARS CoV-2, it has been there. So COVID has been endemic. Now, to emphasize on what I have been asked to do as to what is the current clinical scenario. This is the 73 years old female, a medical doctor who had mild hypertension, who got in touch with me yesterday. And I have not changed any verbatim. What she said, I requested him to write. I'm thankful to her. So this is on, she said on 30th of May, she woke up in the morning with bad headache, myalgia, severe backache, fever ranging from 100 to 101, slight throat irritation. On 27th, she had gone for a dental CT scan to a clinic, and she presumes, and she is very emphatic that she got it from there. On 31st, RT-PCR was positive. There was thrombocytopenia on CBC. And she was vaccinated with Pfizer vaccine thrice with one booster because she was based in Singapore at that time. And for the current illness, she took only paracetamol, and fever lasted for 4 to 5 days. And now, After say sixth or seventh day, I felt extreme feeling of thirst, dry lips, throat, and could hardly speak because of the dryness. After fifth day, there is no fever in the morning, but records about 99, 90.3 in the evening. The saturation is normal. I had loose motions on fifth day onwards, taking Derolic sachets. And on sixth day, I started having running nose, bouts of cough with slight sputum. Now, then she also emphasized that two of two of his family members also got COVID, and they had loss of taste and smell. Now, these are the about 10 cases that we have seen, me and my colleagues have seen at PSRI. Uh, and if you see the profile of the cases, these are majority are young people from 20 to 51 years of age. They don't have any comorbidities. Uh, Four of the 10 cases have some travel history. Majority, all except one, were vaccinated. All had fever. Majority had cough. The rhinitis was present and loss of smell and did not see. And the duration of illness was 4 days, 3 days. Duration of fever was 4 days, 3 days, 4 days, 3 days, 4 days, like this. Now, how do I manage the present episode? What I'm doing is, and I'm seeing several patients on online, and I don't see them personally though. In the symptom, I give only symptomatic treatment: isolation, paracetamol, antihistaminics, cough syrup. Monitor SpO2 in susceptible population, and these are the ones who are elderly, not necessarily 60, 80 plus or 75 plus, those on steroids, those who are on chemotherapy, those who have rheumatological diseases, have CKD or chronic liver disease, and several others, those who are on mycophenolate or so many other drugs. They have to monitor their SpO2 should they get COVID. There is no role of antibiotics whatsoever. Now, the frequently asked question to me is, when should we test? Now, suppose a healthcare worker becomes positive, when can he join back the duty? As per the current literature, the person may remain positive up to 14 days, but it's very difficult in today's time to ask somebody to be isolated for 14 days. So I am testing them on seventh day, and majority are becoming negative, so that they become free birds. And they should report. I also ask them to report in case of breathlessness or low SpO2 or severe chest pain or any other alarming symptom. Now, the the previous madam has very nicely given WHO recommendation of booster vaccination. This is also a frequently asked question to me as to vaccination is not available like flu vaccine or pneumonia vaccine. My personal opinion is that there is no need for mass vaccination as this is a different strain. And I don't have to tell about strains, you all know about it. But uh, initially, when the literature came in the year 2000 about vaccination, and I was also a member of adjudication committee for Covaxin trial. All trials claim that there was uh, decreased incidence of COVID infection in a randomized trial. But subsequently, the information came that COVID vaccination does not decrease the rate of infection, it decreases the rate of severity, decreases the rate of hospitalization, and decreases the rate of ICU, and also decreases mortality. Since this particular virus which is circulating around does not cause illness, a serious illness in healthy people who are not immunocompromised, I do not think that we are in for mass vaccination. However, as the WHO has recommended, those who are susceptible population, which I need not re-recite, should be considered for vaccination, but the government of India has to come out with the policy. Now, the deaths so far reported in India, like from Mumbai and from Delhi also and from other places, have been in patients with severe comorbidities, and that we call it that deaths with COVID and not due to COVID. Now, this is a phrase that I am using to emphasize that uh, COVID is not causing death as it was causing during the pandemic time, where the healthy people, absolutely healthy people, got pneumonia and ARDS, required ventilator. And of course, it requires close surveillance, and it was very enlightening to listen to the previous speakers, the top virologist telling us as to how the surveillance, and it was heartening to know the ICMR experts as to how nicely it is being followed up. So, concluding my presentation, there is a resurgence of COVID, which is Omicron subvariant, and of course we know about it. It is causing mild illness for 5 to 7 days. There is no need for any antibiotics or antiviral or steroids or antibodies for the management. Susceptible population should follow COVID appropriate behavior. Now, the isolation is a very difficult thing to do for healthy people to be out of job, but it is important to protect others, especially if there are susceptible people in the population, in the house or wherever they are working. So, therefore, it is. I would urge the government of India and the ICMR and their bodies to come out with the clear guidelines for all of us to follow. So, ladies and gentlemen, I thank you all for patient listening. And one thing I would like to emphasize that it is Dr. Ashok Rattan is a star microbiologist, whether he was in AIMS or not in AIMS. And it is always a pleasure to be talking when he is moderating the session. Thank you very much.
Thank you very much, sir, for making things very clear